Thanks a lot. Thank you for the invitation. Thank you, Moritz. I'm really happy being here with you. It was very interesting also for me to search and see what is there regarding rehabilitation in the literature regarding GNAO1. So I performed a literature search in PubMed, in total 17 papers, not a single article really referring to a rehabilitation concept or a plan of treatment. The only some interesting things definitely were, where the fact that pretty much parents and families and caregivers, as well as health professionals, emphasized the fact that the shattered expectations have to be early enough taken into consideration in order to plan an adequate and a proper rehabilitation problem, and how really to closely monitor the families and to closely secure their development and their life from day to day. And there were also issues of accepting treatment. So in generally the whole goal setting and the process of choosing the modalities that would support the children, best support the children in rehabilitation had to be rethought. In generally, in child rehabilitation, we always need to have the child in the middle. And we are, all of us health professionals around there, taking care and monitoring together. But the most important thing is that all of us have the same view of the patients, that we all of us have the same goals. We know that we follow a specific assessment that has been predefined already, and of course what is ideal in child neurology and rehabilitation, that we follow the ICF, the WHO ICF model, so that in that case as it is of particular importance that we know the health condition well. We know what's happening with the body structures and the body functions, what are the activities that have to be taken, have to be done, have to be performed by the child, what is realistic in their everyday life, what participation is expected, and how do we improve it, and how do we modify personal and environmental factors in this. In GNAO1, we're talking about neurodevelopmental disorder with early onset epilepsy often, and then significant movement disorder. Regarding activities, we have to make sure that the child is able to play, is able to communicate non-verbally or verbally, to be able to change and maintain a body position that could be walking, eating, washing itself. Regarding body functions and structures, we're talking about the level of consciousness, mental functions, language, muscle tone, control of voluntary movement, structure of the limbs, the level and frequency of dyskinetic crisis. Participation has to do with social contacts, with visiting school, education, family life, and environmental and personal factors include both the interventions that we perform, the health services and health policies, and of course the demographics of the patient itself, and of course the variant, the specific variant that we're talking about, the severity of the type of the GNAO1. What is important also in generally in child neurology, and when we're talking about rehabilitation, is that we always have a disease which leads to a movement disorder, but we also have the immobility, which worsens pretty much the movement disorder. So we have immobility-related complications, and these exactly are the ones that we try and we wish to to address very early. What does a therapy, and regarding the goal setting, I would present, for example, what would be a therapeutic success mean for our patients, that they can sit stably for longer than 45 minutes to participate in an hour in the school or in a lecture, that they can be able to overcome one step to go on the balcony, to get on the balcony of the house, that they are maybe able later to prepare a sandwich and eventually eat independently. And for these goals, we have to plan individual therapy, which will include muscle work, adaptation, and assessment of the results also. And of course, the goal is that all our work emphasizes indeed in improvement of the daily functions of the child. What we should know and consider when treating a child with a GNAO1 disease is that we have children that their cognition is variable. We have partially progressive symptoms which may lead to total dependence. We have very often hyperkinetic stati, and sometimes we have a recovery, but not always. We reach the same baseline as before the status. We have massive dystonia and muscular hypotonia, fatigue and lack of energy that we already discussed extensively yesterday, scoliosis and spine deformities. We have orofacial problems, speaking, eating, drinking, a slow motor development and the loss of skills in the process. We have difficulties in the transfers, getting up from the floor. Walking is often not the rule. In walkers, we have reduced gait endurance, and a wheelchair is often also the rule. Immobility increases with time. Respiratory insufficiency triggered due to infections, frustration, and pain. And for us as therapists and as child rehabilitation experts, we have to take all these challenges and to turn them around, turn them upside down, and try to optimize the rehabilitation program for this. We need to start with early support as soon as possible, already in infancy, achieve the best possible motor function and independence, have the patients ready also for a DBS later, for medicational treatment that can be provided, increase enjoyment of movement, reduce dystonia with medication, eventually with DBS, avoid pain and discomfort, and pay attention to fatigue, optimize positioning of the patient, early introduction of medical aids, power wheelchair, the use of orthoses to maximize independence, systematic instruction of patients and care staff, and the revision of the exercises, constant revision of the rehabilitation plan, and psychological support. And I will present you a little bit what is the Cologne concept of the in child rehabilitation. We have a university child rehabilitation department, the only one in Germany, and we're very proud of it. Here's the team of the doctors and the physiotherapists. It's focusing on gross motor function, and that's why my presentation today is focusing on gross motor. So a big element in the rehabilitation program here in Cologne is the utilization of whole body vibration as part of the rehabilitation program. Here you see a 3-year-old girl with a bilateral spastic cerebral palsy who is training on side alternating whole body vibration system. She performs different exercises to train her abductors muscles, to train the legs, to train standing, and also to train her shoulders, always in under thorough cooperation with the physiotherapist. And the systems that are commonly used are either a platform for children who can stand, or the use of a tilted table, where the patient is strapped on and can receive the training like this. The concept that in generally our patients go through, and they're pretty happy also for it, is called Auf die Beine, which means on your own feet. It is an interval rehabilitation program which includes home training, and it has a duration of 6 months. Pretty much we have a baseline initially where we examine the patients, and we decide together with the families what are the rehabilitation goals, what we should improve, and how will we measure it. Then we have a stay in the rehabilitation center for about 2 weeks, where we train with a lot of different modalities, including the whole body vibration. And then a 3-month training, home training program, where the families receive this whole body vibration apparatus and system, and they train at home. They come back again. We see 3 months later, we see how much they have improved, what can be fine-tuned in their training, and how can we maybe have a more difficult, a more challenging training in the next 3 months, and then the patients go back again and train at home with their machines. During the stay, we have a functional, routine-oriented physiotherapy. We have strength training. We have really a gym for these kids. We have a big room with treadmill training. Also, robotic treadmills are included, but also a lot of funny activities that are there and can be used. And there is also an exercise pool, which is very welcome by the patients. They usually swim once a week there. And these stays can be performed again and again, and depending on the health insurance that the children are insured here in Germany, they can have it up to 5 times within a timeline from pretty much the 3rd, 4th year of life, so that the children can really cooperate with whole body vibration up to 25 years of age. So also includes young adults. Of course, you can imagine that the most common, this is a pointer? Yeah. The most common diagnosis for the participants in the center are cerebral palsy, followed by spina bifida, and also skeletal anomalies. Osteogenesis imperfecta is also a major part of the patients here in Cologne, in the Center for Rare Diseases in Cologne. But of course, there is experience with patients with dystonia and dyskinesia, and this is what I will try to share with you now. I checked a little bit how our patients with GNAO1 performed in the last years. A big important part of the stays in the department is, of course, to train the parents, because they will perform the training at home with the child, to instruct them how they will be the perfect instructors, the perfect coaches for their kids, and each kid goes home with the logbook of 4 or 5 exercises. And of course, the training at home looks a little bit more challenging, but we also welcome the other siblings and the rest of the family to participate in it. The children train for 6 months, 10 times a week, and 3 times after 3 minutes, 3 to 6 exercises. We have a logbook also, and we follow up the patients. And the whole idea behind whole body vibration is that we have as many repetitions as possible. Imagine that training with 15 hertz means 15 repetitions per second. So in a 3-minute long training with this side alternation system that we're using, we have 2,700 repetitions for the child. We're talking about a massive number of contractions, of muscle contractions that we cannot reach through a simple active training. And the whole idea is, of course, to here not just to fight fatigue, but in order to fight fatigue, to induce also fatigue, to create new champions among our patients. The therapy goal determines also the required frequency range. So in children who primarily have ataxia, have balance problems, mobilization issues, we train them with relatively low frequencies, 5 to 10 hertz, where we have a central control dominant voluntary training. Further, when we train reflex-based and spinal cord dominant, we use frequencies of 12 to 20 hertz, where we have a complete contraction and retraction, relaxation, sorry, contraction and relaxation cycle of every muscle. It's about 25 milliseconds per contraction and relaxation. So up to 20 hertz, we have this option that the muscle really makes it to relax. Also, we have, okay, here I've left den in German, but stretching of the muscles, spasticity management, coordination, and body perception. We also use it a lot in patients with autism spectrum diseases, and for pain, muscle pain management. And when we're going to muscle performance, we go further higher, 20 to 40 hertz. Usually we will not go in children higher than 25 hertz, where we do not have a relaxation phase. We have a continuously increased muscle tone and really bodybuilding of the children. In this patient, you see also a guy with a cerebral palsy, bilateral spastic cerebral palsy, how his gait has been improved, and we have also measured his gait analysis. It's not this video, but it has been on a gangway, where you see that the step length has significantly increased. The velocity has obviously increased within the 6-month training period. And what is very important regarding efficiency, energy efficiency, is the pathway to distance ratio. This is pretty much a ratio that shows us how much distance a patient has to cover in order to walk a predefined distance of 1 meter. So if I'm walking 1 meter like this, or like this, then the energy that I have to invest in order to perform this movement is much better, much higher. So you see that this patient was walking at the beginning of the training 7.7 meters for 1 meter of distance, and 2.65 in the end. Here's another boy with also a bilateral spastic cerebral palsy, baseline walk using a posterior walker. Here to walk 3 months later, can walk with a little bit support, and 1.5 years later we have this development. I'm showing BSCP patients because they are the most common ones that we see, but in generally in the non-progressive also diseases we have similar development. Here is what I found regarding our GNAO1 patients. In total we had 7 participants, and I could not find data for one patient. They were somewhere, they were somewhere lost. I think they were too many years back. Then we had one patient that has not finished the training. It's patient 1, is participating now in the training, and another 2 patients, patient 5 and 6, that were, well, they were not, that it was not possible to perform an objective test, an objective GMFM 66, not 6, 66, during the test, during the stay. So for patients 5 and 6, the therapists have reported that they definitely improved their sitting position, and what is also often measured during training in patients who cannot stand properly is the angle in which the patients fall or lose control when they are sitting on the tilted table, and this had improved in both patients. From the other patients now here who could perform the GMFM 66, we saw a significant, I mean, we have only 4 patients here, but we saw a significant increase in the 6 months of training, which was at least, which has stayed like this, at least in patients 2 and 3, has stayed also in the follow-up meeting 6 months after the training. Yeah, we have results from other patients and other patient cohorts. What I would just say in order to wrap it up and finalize is that I believe that relative similar progression of the disease is what we have seen in the patients with ataxia, and we have children with progressive and with non-progressive forms, and probably I would see the GNAO1 patients somewhere between these 2 cohorts, and in these cohorts we saw that they really improved both GMFM 66 and their walking capacities during this training. Topics for discussion is that, of course, we have a significant variability of clinical pictures, and we don't have good, that well validated or that well available tools in order to measure our patients. Sometimes they're also not used properly. The lobby is not strong enough. The quantity of services is still not adequate. And also the whole idea that I would bring here in discussion is that the outpatient rehabilitation, the rehabilitation as a home training should be something that has to be strongly considered also in patients with the GNAO1. And the active involvement of all stakeholders is critical to achieve optimal outcomes, to improve quality of life, to improve rehabilitation outcomes, to improve research in rehabilitation, and to have a better and holistic approach regarding treatment of our patients and utilizing all options that modern technology can offer us. Thank you.